My name is Leslie O'Hirhian, and my philosophical focus concerns the four paradigms of our field: person, environment, nursing, and health, and examines them through the lens of Faye Abdallah's patient oriented approach theory. The title of my poster presentation is More Than Their Disease and challenges us as nurses to look beyond the disease process and treat the person within the context of their environment to improve their health outcomes. I'll begin my focus on the paradigm of the person. In so doing, we nurses must face some hard truths. There are entire groups of people disadvantaged by health disparities, and many of these disparities occur across racial and ethnic lines. Racial disparities influence healthcare utilization, patient outcomes, and morbidity or mortality. They are not, however, the singular driver of poor health outcomes for patients. But how did we get to this point? How do we get to the place where persons are divided along racial and ethnic lines? And how does this impact the paradigms of nursing, environment, and health? Consider the following as the background for how race, and more specifically, the association with dark skin and inferiority and physical well being, became a foundational tenet in healthcare discourse. The construct of race is based on faulty premises and continues to be redefined throughout healthcare. Racial classification began with Carl Linnaeus and his system for classifying humans based on their geography and skin color. The philosopher Immanuel Kant proposed race be considered a fixed characteristic, with humans belonging to one of four races: blonde/Northern European, copper red/American, black/Senegambian, and olive yellow/Indian. Kant also proposed that some races were inferior to others based on their phenotypic characteristics. He proposed the superior race to be originating from white brunettes, with all other darker races being inferior. The origins of race as a construct for classifying humans is also the basis from which discrimination began, asserting the superiority or inferiority of one race over another based on perceived disadvantages based on phenotypic presentations. This background, though largely baseless in empirical scientific data, continues to shape the discourse around the aforementioned healthcare disparities along racial lines. Despite cultural competence and an awareness of social determinants of health being a forefront concern for nurses and providers, health disparities remain a public health crisis. Herein lies the intersection between person and health. From pain management to perioperative care and post op health outcomes, ethnic minorities, and particularly Black and African Americans, still realize poor health outcomes than their white counterparts. Furthermore, these racial disparities influence healthcare utilization, patient outcomes, and morbidity and mortality. In a study of perioperative total joint arthroplasty patients, African American patients were younger, experienced a longer inpatient stay, and were more likely than their white cohorts to be discharged to a different facility instead of their home. The disparities do not exist only in adult patients. Race is also a driving factor in postoperative mortality and surgical complications with pediatric patients with congenital heart disease. In a study of 55,859 pediatric patients, Black and white children were compared. The Black patients experienced significantly worse postoperative outcomes than their white counterparts. These complications were not minor. These outcomes included thromboembolic complications, reintubation, and even cardiac arrest. Since research aims to push the conversation further through innovation and insights into how we provide care to patients, it cannot be ignored that much of this research is based on how subjects identify and categorize themselves. Though there is no direct biological significance between races, the correlation between poorer health outcomes and minority races still resembles the inferiority categorizations of Linnaeus and Kant. And while cultural competence measures strive to improve these poor health outcomes, based on racial classifications, the outcome is still the same. People of color are viewed certain ways with respect to morbidity, mortality, and the disease process. So, how does a person's environment contribute to their poor health outcomes and disease processes? Social factors are contributing determinants of health that are often dismissed or disregarded in healthcare spaces. Factors such as reliable, affordable transportation can mean the difference between being compliant with follow up doctor's appointments, well visits, and ability to pick up prescriptions. Having to work during business hours so that the person can pay for healthcare often means missing appointments or having to reschedule because of work conflicts. For some patients, the choice becomes prioritize work or prioritize wellness. Just as humans are more than their race, patients are more than their disease process, and there is more to their disease process than the implications of their racial presentation. For some patients, there are cultural pressures against westernized healthcare and medical interventions. Peer pressure may contribute to some patients choosing to avoid safe sex practices and contraceptive measures. Other patients make deliberate choices to forego important life saving medication because of adverse side effects. For example, a patient may avoid taking antidepressants because it contributes to decreased libido. Without digging deeper and assessing the patient's environmental circumstances and motivations, nurses will continue to see patients as merely their disease presentations. Faye Glenn Abdullah proposed that we, as nurses, view patients as more than their disease process, and her patient oriented approach theory and her work helped shift nursing approaches away from the medical model. Through a nursing model, we are able to care for the human in ways the medical focus does not, and this affords us the space to focus on other underlying factors affecting the patient beyond their race and phenotype. By focusing more on the social determinants of an individual's health, we nurses are able to look beyond race, look beyond the disease, and provide holistic care for the patient as an individual human and not an ill-fated demographic statistic. My artwork reflects my philosophy, which is rooted in Abdullah's approach, an assessment of how focus on the disease process limits us to categorizing patients in a way no better than Linnaeus and Kant. Instead, I argue that we nurses must assess the social determinants of health and environmental factors for the individual person and address the circumstances contributing to the disease process in that person. In conclusion, I challenge us as nurses to carry the torch of Faye Abdullah and focus on more than their disease. Look beyond the race and disease presentation to heal the person and the situation or setbacks that got them in that position to begin with. That is my personal philosophy to nursing. Nurses should assess the social and environmental determinants contributing to the disease process of the individual person, diagnose what those problems are, plan specific, measurable, achievable, relevant, and time-bound solutions for those problems. Implement those strategies through education, demonstration, and involvement with the multidisciplinary team, and evaluate the results based on the evidence of effectiveness. Thank you.